Welcome to the deep dive. Today, we're unraveling a bit of a mystery in the equine world, something called equine pharyngeal lymphoid hyperplasia, or PLH for short.
Yep, PLH.
For many horse owners, it sounds complicated, maybe even a little scary. But what if I told you it's often just, a normal part of growing up for a young
Oh,
horse?
it's often the case, yeah.
So our mission today is to take the articles and research you've shared with us and really dig in, pull out those vital nuggets of insight.
Get to the core of it.
Exactly. We want to cut through the veterinary jargon and give you a clear understanding of PLH. Explore that fascinating connection between a horse's immune system, its environment, and even the demands of being an athlete.
Hmm.
You should walk away with some surprising facts, hopefully, and practical takeaways, really separating the normal from the needs attention.
It's true. And what's so intriguing about PLH is just how incredibly common it is. Really common.
Right.
Yet its actual significance is, well, it's frequently misunderstood. So this deep dive is crucial, I think, for parsing out what's really going on.
Okay, let's jump right in then. When we talk about equine pharyngeal lymphoid hyperplasia, PLH, is it just a fancy way of saying a horse has a sore throat? What exactly are we dealing with here?
That's a great question, and it does highlight a common misunderstanding. PLH is actually the enlargement and inflammation of specialized lymphoid tissue.
Lymphoid tissue.
Yeah, in a horse's pharynx, which is, their throat. Now, unlike us humans, we have distinct tonsils, right?
Mm-hmm.
Horses, they have these small, kind of diffuse clusters, lymphoid follicles. They're scattered across the roof and the sides of their pharynx. Think of them like a widespread network of immune outposts.
Okay, so not like our tonsils, more spread out.
Exactly. And it's also important to differentiate. There's acute pharyngitis. That's a short-term inflammation of these tissues.
Right.
But PLH, that's what we call chronic pharyngitis. It's a more persistent enlargement of those lymphoid follicles.
Gotcha. That distinction between acute and chronic, that's really helpful. So if this is about these lymphoid tissues reacting, who are we seeing this in most often? Are certain horses more susceptible, or does it affect all horses pretty equally?
This is where it gets particularly interesting. We predominantly see PLH in young athletic horses,
Young athletes.
typically between 1 and 4 years of age. And many cases really peak around 2 to 3 years old.
2 to 3, okay.
But here's the key insight, really. In a lot of instances, especially the milder ones, what we categorize as grade 1 or maybe grade 2.
Which we'll get into, I'm sure.
Yeah, we will. But in those cases, PLH is considered a completely normal physiological response. Normal. It's simply a sign that a young horse's developing immune system is actively encountering and reacting to new environmental pathogens, irritants. This is meeting for the very first time.
So it's like their immune system is just learning the ropes.
Precisely.
Yeah.
And as the horses mature, usually by 4 or 5 years of age, these lymphoid follicles, they tend to regress. They blend more seamlessly with the surrounding tissue, become less noticeable.
Oh.
So many mild cases are actually asymptomatic.
Yeah.
They show no outward signs at all. You'd only find them incidentally, maybe during a routine vet check or an endoscopic exam for something else.
Wow, that's a huge shift in perspective right there, this idea that it's often just normal, part of growing up. But if it's so common, what exactly triggers these lymphoid tissues to react? Our sources mentioned it's rarely just one thing, right? They pointed to a few key areas.
Exactly right. The causes are almost always multifactorial, usually stemming from a combination of irritation and immune system stimulation.
Okay.
Essentially, it's a local immune response to various things the horse inhales or, ingests. The most common triggers often involve infections.
Infections make sense.
Think of it like this. Your horse's developing immune system is being introduced to all these new bugs. The primary culprits are often various viruses. Things like common equine versions of herpes.
Like rhino, EHV.
Exactly. EHV1 and EHV4, which cause rhinopneumonitis. And equine influenza virus plus rhinoviruses, adenoviruses, paramyxoviruses, just some of the everyday respiratory viruses horses bump into.
So a whole range of viruses.
Definitely. And beyond viruses, bacteria can also get involved, often as secondary invaders, after a virus has sort of weakened the defenses.
Opportunists.
Pretty much. This can include common bacteria like Streptococcus zoepidemicus or even the bacteria that causes strangles, Streptococcus equi. Mycoplasma has also been looked at.
Okay, so viruses, bacteria. What else?
Well, it's not just infections. Environmental irritants play a really significant role.
Like dust.
Absolutely. Imagine a stable with dusty hay, maybe poor ventilation leading to high ammonia fumes from soiled bedding. These can all irritate the sensitive tissues in the throat. Even smoke inhalation could be a factor. Then there's mechanical irritation. For active athletic horses, just the sheer force of air turbulence during high-speed exercise can actually cause irritation in the pharynx.
Wow, just the act of breathing hard.
It can contribute. And sometimes, though less common, even repeated or maybe rough endoscopic procedures could add to the irritation.
Makes sense.
And of course, as we mentioned, young horses, 1 to 4 years old, they're inherently more susceptible. Their immune systems are still learning, encountering all these new antigens.
So still developing.
Exactly. And finally, well, some horses might just have a genetic predisposition. They might just be more prone to it.
Right. So given that it can often be normal, when should you actually start to worry? What are the practical signs that might tell you a horse is symptomatic rather than just going through that typical developmental stage?
Yeah, that's the key question.
Yeah.
And it's crucial to remember, again, that many horses with those mild grade 1 or 2 cases, they show absolutely no symptoms. Zero. You wouldn't know without that scope.
Right, the incidental finding.
Exactly. When clinical signs do show up, they're often quite subtle, and they can easily be mistaken for other, general upper respiratory issues.
Like what?
You might notice a mild nasal discharge. Could be clear, maybe a bit sticky, sometimes even thicker and cloudy, sort of mucopurulent, if a secondary bacterial infection takes hold.
Okay. Discharge.
A dry, intermittent cough is pretty common, too. Sometimes it gets worse during exercise.
Coughing.
Less often, much less often, you might see signs of actual throat discomfort, like maybe difficulty swallowing, what we call dysphagia, or a reduced appetite, maybe frequent swallowing, but that's less common.
Okay, those are more subtle. What about performance?
Right. The more concerning signs tend to be performance-related, and these are usually seen in the more moderate to severe cases. So grade 3 or 4. A horse might show exercise intolerance or just poor performance. Seems to tire easily, maybe just not performing at their usual level.
Not themselves.
Exactly. You might also hear an abnormal respiratory noise during exercise. Could range from a mild gurgle to a more pronounced sound, an inspiratory or expiratory noise. That's due to the restricted airflow or sometimes even a temporary collapse of tissue in the throat area.
A breathing noise. Okay.
Yeah. And prolonged recovery after exercise is another indicator. They just take longer to cool down, catch their breath.
Got it.
But generally, let me stress this, in mild cases, PLH has very little impact on athletic ability unless it progresses to a more severe stage.
So the severity is key.
Absolutely. And to accurately assess that severity, veterinarians use an endoscopic grading system. This is really the cornerstone of diagnosis.
Okay, tell us about the grades.
Sure. So grade 1, you see small scattered lymphoid follicles. They're distinct. This is considered normal.
Grade 1, normal.
Grade 2, the follicles are larger, more numerous, maybe starting to merge a bit, what we call coalescing, perhaps with a touch of redness. This is often still normal or non-clinical, not causing problems.
Okay, still often okay.
Grade 3. Now here, the follicles are large, very numerous, significantly merged or coalesced, covering most of the upper throat wall. You'll see noticeable redness, possibly some discharge, some exudate. These are more likely to be clinically significant, causing issues. Grade 3 getting serious. Grade 3, this is the most severe. Widespread enlargement, what we call hypertrophy, significant inflammation, maybe even ulceration, and often a lot of discharge or exudate. At this point, it's physically impeding airflow and causes pretty significant clinical signs.
Grade 3, definitely a problem. That grading system sounds incredibly useful for making sense of it all.
It is. It standardizes things.
So if you suspect PLH, how do veterinarians actually get that definitive diagnosis? What's the process for getting that clear picture?
Well, the diagnosis relies primarily, almost entirely, on that endoscopic examination of the pharynx. The scope, exactly. But before that, of course, the vet will gather a thorough history. Asking about the horse's age, its discipline, is it a racehorse, a pleasure horse, any past respiratory issues, and importantly, the environmental conditions it lives in, stabling, turnout, bedding, hay.
All the background info.
Yep. Then, a general physical exam, especially focusing on the respiratory system, listening to the lungs, checking lymph nodes, etc. But the upper airway endoscopy is truly definitive. The horse is usually given a mild sedative just to keep him comfortable and still.
Right.
And a flexible endoscope, a thin tube with a camera, is gently passed through the nostril into the throat. This allows the veterinarian to clearly visualize those lymphoid follicles and apply that great eye through 5E system we just talked about.
See it directly.
See it directly. And it's also a crucial opportunity while they're in there to check for any other concurrent issues in the upper airway.
A good point. Like what? Yeah.
Things like epiglottic entrapment, where that little flap over the windpipe, the epiglottis, gets caught. Or laryngeal hemiplegia, often known as roaring, where one side of the larynx doesn't move properly. Or maybe dorsal displacement of the soft palate, DDSP, where the soft palate flips up over the epiglottis.
So you can check for multiple things at once.
Exactly. It's efficient. Now, other tests can provide supporting information, but they are usually secondary to the endoscopy.
Like what kind of tests?
For example, a microbial culture. You take a swab from the throat, the nasopharynx. That can help identify specific bacteria if an infection is suspected. Though interpretation can be tricky because there are always normal bacteria living in the throat. It's hard to know if what you grow is actually causing the problem.
Right, it could just be bystanders.
Exactly. Viral testing, using swabs or washes for PCR, that's a DNA-based test, can pinpoint specific viral infections, especially useful if there seems to be an outbreak. Blood tests, like a CBC, a complete blood count, or other blood chemistry panels, might show signs of underlying infection or inflammation. Maybe high white cells, or indicators of inflammation like fibrinogen.
General health markers.
Yeah. Imaging, like X-rays of the pharynx, can help rule out other things entirely, like foreign objects stuck in there, maybe soft tissue masses, fractures, or issues in the guttural pouches, those air sacs near the throat. Ultrasound of the pharynx area might also reveal abnormal structures like masses or abscesses sometimes.
So ruling things out.
A lot of it is ruling things out.
Yeah.
And finally, it's vital for the vet to consider other potential conditions that could mimic PLH symptoms, like simple rhinitis, nose inflammation, or laryngitis, voice box inflammation, or maybe dysphagia from something else entirely.
Right.
And crucially, if the main complaint is poor performance, exercise intolerance, PLH should only really be considered the primary cause after eliminating all other possible reasons, because often mild PLH isn't the main culprit for significant performance issues on its own.
That's a really important point. Don't just jump to PLH for poor performance.
Correct. Investigate thoroughly.
Okay, that really helps clarify the whole diagnostic journey. So let's say you have a horse that is diagnosed with PLH, especially those symptomatic or higher grade cases, grade 3 or 4. What does that mean for treatment? How do vets approach managing this?
Right. Well, first, it's really important to reiterate that for most asymptomatic grade version 2 cases, especially in those young horses.
The ones just figuring things out.
Exactly. For them, no specific treatment is necessary. The condition often resolves on its own, spontaneously, as the horse matures and its immune system develops. Time is often the best medicine there.
Okay, benign neglect sometimes.
In a way, yes, watchful waiting maybe. But for those more severe cases, grade 3 or 4, or horses that are showing symptoms like coughing or poor performance directly linked to it, then the focus shifts. It's about reducing that inflammation, controlling any secondary infections that had jumped in, and crucially minimizing those environmental irritants we talked about.
Right, the dust and ammonia.
Exactly. So number 1, rest. This is paramount. We're talking anywhere from 2 to 6 weeks away from intense exercise.
2 to 6 weeks? Okay.
Sometimes even longer, maybe up to 8 weeks for really severe cases. This is essential just to allow that inflammation in the throat to physically subside.
Let things calm down.
Makes sense. Give it a break.
Then anti-inflammatory medications are often used. This could be general anti-inflammatories, like NSAIDs, that's non-steroidal anti-inflammatory drugs. Things like bute or Banamine. They help with the swelling and any discomfort.
Standard anti-inflammatories.
Yep. For more severe inflammation, systemic corticosteroids might be prescribed, like dexamethasone or prednisolone. These are more potent anti-inflammatories.
Okay.
Sometimes vets use topical corticosteroids directly in the throat, delivered maybe as throat sprays or nebulized medications, often mixed with things like DMSO or glycerin.
Sprayed right on it. Yeah. Though it's worth noting that the effectiveness of these kind of custom topical preparations, well, it needs more solid scientific proof. It's done, but the evidence is still developing.
Gotcha. What about antibiotics?
Good question. Antibiotics are only prescribed if there's clear evidence of a secondary bacterial infection.
Only if needed.
Only if needed. Signs like thick, purulent, pus-like discharge, maybe a fever, and Ideally, a positive bacterial culture that shows something significant growing.
Yeah.
They are not effective against the primary viral triggers, remember.
Right, viruses don't respond to antibiotics?
Exactly. If bacteria are involved, then broad-spectrum antibiotics might be used.
Okay. And the environment.
Hugely important. Environmental management is key. Things like improving stable ventilation, feeding wet or soaked hay to cut down dust.
Simple but effective.
Very effective. Using dust-extracted bedding, avoiding sweeping aisles when horses are stabled, trying to identify and remove any specific allergens if possible. Basically maintaining a very clean, dry, low-dust environment. This is all about removing those constant irritants.
Taking away the triggers.
Precisely. And supportive care can also be important. If the horse is having trouble eating or swallowing due to throat pain, maybe offering soft feeds, ensuring they stay hydrated, potentially with fluids if needed.
Okay. Anything else?
Well, there's a sort of debated area around immunomodulation or vaccination. Some suggest maybe more frequent flu and equine herpes virus vaccines might help bolster the immune system generally, but the specific scientific evidence directly linking this approach to the actual resolution of PLH itself is, well, it's limited. It's more theoretical.
So not a proven fix for PLH specifically?
Not really, no. And then, as a very, very last resort, this is rare for extremely severe chronic gray throat lesions that just aren't responding to anything else and are causing significant problems.
Right.
Surgical or physical ablation might be considered. This involves techniques like using lasers or chemical cautery or cryotherapy, freezing, to basically remove or destroy the excessive inflamed lymphoid tissue.
Wow, that sounds intense.
It is. And these are definitely last resort options. They come with risks like significant local inflammation post-procedure, potential scarring, which could cause other issues, and the possibility the condition could still recur. So it's not undertaken lightly at all.
Okay, so mostly rest, anti-inflammatories, and cleaning up the environment.
That's the mainstay for symptomatic cases, absolutely.
That's a very comprehensive approach, really balancing a medical intervention with that environmental common sense. So, wrapping things up a bit, what's the overall outlook for a horse diagnosed with PLH? Are we talking about a long-term issue typically, or do most horses return to full health and performance?
Generally speaking, the prognosis for equine pharyngeal lymphoid hyperplasia is good to excellent, particularly as the horse matures.
That's encouraging.
It is. As we've discussed quite a bit, most cases, especially those milder grade EQ and Anthem 2 ones, they spontaneously resolve or significantly improve just with age. Usually by the time the horse hits 4 or 5 years old, their immune system has matured and the issue fades.
Time heals in this case.
Often, yes. And even the symptomatic cases, the ones needing treatment, they often show good improvement with that appropriate rest, the anti-inflammatory medication, and especially good environmental management.
Okay.
Now, while it was once thought to be, a major cause of poor performance, particularly in racehorses.
Yeah, you hear that a lot.
You do. But the true clinical impact of mild PLH grades Thurston 2 is now often questioned. It might be present, but maybe not the reason for poor performance.
Correlation, not causation.
Exactly. Now, severe cases, grade 3, and definitely grade 3, they are certainly more likely to affect performance, simply due to the physical obstruction or the significant inflammation causing discomfort.
Makes sense.
But even many of these horses, with appropriate management and time, can return to full function. The prognosis might become more guarded if severe secondary complications arise, things like chronic upper airway obstruction that leads to other problems like DDSP, or maybe persistent pharyngeal pain that affects eating. For monitoring, veterinarians often recommend a follow-up endoscopy, maybe 3 or 4 weeks after starting treatment, just to check on the progress, see if the grade is improving. Rechecking blood work might be needed too.
Check things are heading the right way.
Yep. And regarding prevention.
Yeah.
Well, methods for controlling common viral and bacterial respiratory diseases in general, good biosecurity, vaccination protocols for things like flu and rhino, these should theoretically limit herd problems that could trigger PLH outbreaks. But it's worth noting again, there isn't extensive hard data specifically supporting this as a direct preventative measure for PLH itself. It's good practice for overall respiratory health, though.
Right. Good general advice anyway.
Absolutely.
Wow. This has truly been an in-depth exploration of PLH. It really is fascinating how something so common can range from being, a completely normal physiological
That's
response
part of growing up.
to potentially a significant performance-limiting issue,
Yeah.
and how understanding those nuances, those grades, the context really matters for you as a horse owner or caretaker.
Absolutely. And if we connect this to the bigger picture, maybe step back for a second, it really raises an important question, I think, about how we interpret abnormal findings,
Hmm.
especially in young, developing animals.
Interesting point.
Not every finding that deviates from some textbook perfect state is necessarily a disease that requires intense intervention, right? Context, observation, understanding the severity, the clinical signs, or lack thereof, they're absolutely key.
That is a powerful point. Not everything different is bad.
Precisely.
So here's a final thought for you, the listener, to maybe mull over. Given that PLH in its milder forms is essentially an immature immune system learning to cope with its environment, how might this change your perspective on other common, maybe self-limiting conditions you see in young animals? Perhaps seeing them less as immediate ailments that need fixing, and maybe more as just a natural part of a complex developmental process, something to consider.
Definitely food for thought.
Thanks so much for joining us for another deep dive. We look forward to exploring more with you next time.